Good evening, everyone. Thank you very much for coming. I hope everyone is doing fine. Today, inshallah, we have a very nice presentation from a very nice colleague and a very close friend. Today, I'm very happy to introduce Dr. Hanan Mal. But before we start the presentation, I would like to welcome all of you. I just want to make sure that you have noticed that we have a new WhatsApp group that we're formulating, so everyone can, whoever wants to join the WhatsApp group and wants to have the registration links, can either have the registration links from the WhatsApp group or from the Twitter account or from the Facebook account. And hopefully we're gonna look at the YouTube channel and adding all the lectures there. We recently added the two last lectures that we had last week. So please, if you want to join the WhatsApp group, you can go to the Twitter account or someone can share the link with you and you will have them. So without further ado, Dr. Hanan Mal is an associate consultant in King Fahd Medical City. She is a gynae oncologist, inshallah, and she's going to talk about a wonderful presentation. And she's a very nice presenter. I love her presentation. I love her slides and the way she gets and cuts the audience. I hope that, and I'm sure that you're going to find this a beautiful presentation, inshallah. So without further ado, Dr. Hanan, I'm going to stop sharing my screen so you can share yours. Can you share your screen, please? Turn on the mics, please. Turn on the mic.
Okay, hello everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Haytham, for your lovely introduction. Of course, I'm here today to present to you an overview of endometriosis. Whatever I'm going to present today is going to be the tip of an iceberg, and endometriosis is like the black hole of gynecology. It's such a huge topic, and it involves such a huge number of ancillary and multidisciplinary physicians and ancillary staff that we will never be able to cover it in an hour, 2 hours at all. So basically, what we're going to be doing today is we're going to be discussing briefly an introduction about endometriosis. We're going to talk a little bit about the pathophysiology, which is very interesting because endometriosis is yet to be fully understood as a disease. We're going to look into some of the major theories that are out there. I'm going to talk a little bit about the anatomy of endometriosis. Then we're going to cover diagnosis and clinical manifestation. We're going to have a bit of a focus on the overview of management. So the bulk of our discussion is going to be in that last part, in the overview of management of symptoms of endometriosis. The management of infertility is way beyond the scope of this discussion, and I'm pretty sure we can have others who will be a lot more helpful in this particular aspect. So briefly, endometriosis is a detrimental disease. It's considered a chronic disease. It affects around 176 million women around the world. 1 in 10 women are affected during their reproductive years. It has a burden both on society, on psychological well-being of those who suffer from endometriosis. It's also very difficult to determine the actual prevalence of endometriosis, seeing as though that that a lot of patients are either asymptomatic or present with a wide array of vague and non-specific symptoms. 30 to 50% of women tend to present with infertility. The average age of diagnosis is around 27 years old, and most of those who suffer from symptoms suffer from debilitating symptoms that actually affect their day-to-day activities. And if we're talking about the reproductive years, we're talking about a huge chunk of people who are missing school, missing universities, missing work because of severe pain. So it's an estrogen-dependent ectopic deposit of endometrial stroma and glands. And this is the important thing for all of us to know. It's endometrial stroma and glands. So basically, it's presenting in areas other than the uterus or the endometrium itself. Most of the patients present in the reproductive age. and 50% of them actually present with chronic pelvic pain. The sad part of endometriosis is that the diagnosis can be delayed for many, many years if we don't have a high clinical suspicion at the time of presentation. So the pathophysiology, basically the first concept of endometriosis, or the first theory, is the theory of transplantation. This is the theory that focuses on retrograde menstruation. In 1921, Sampson proposed that menstrual cells transport through and out of the endometrial cavity into the fallopian tubes and then disperse within the peritoneal cavity by retrograde menstruation. Now, this concept is very interesting. However, it does have some pitfalls. The pitfalls include failure to explain extrapelvic sites. So as we know, endometriosis can present in a wide array of areas within the human body. Retrograde menstruation occurs in up to 90% of women. However, not all of these women have endometriosis or present with symptoms of endometriosis. And finally, premenarchal endometriosis. A very small percent of women actually of girls present with pelvic pain endometriosis prior to their menarche. So this is kind of a pitfall towards why retrograde menstruation may not be the sole way of transportation. Now we go into another concept, which is chylemic metaplasia. Chylemic metaplasia, proposed by Robert Mayer, suggests that endometriosis is derived from metaplastic cells. Now, this is from the peritoneal mesothelium, Mullerian duct, and germinal mesothelium of the ovary. They're all derived from the chylemic wall of the epithelium, and they retain the capacity to differentiate. So when we have these cells around the abdomen, around the peritoneum, with the effect of estrogen, they can actually develop into endometriotic implants. Again, this can explain the chylemic epithelium. This can explain the presence of endometriosis outside of the pelvis. However, there are still some pitfalls. Now, this was very strange to know, but there is certain cases of endometriosis noted that occur in males, and this could be an explanation for why chylemic metaplasia may be a better theory. Also, endometriosis is primarily located in the pelvis without uniform distribution to other sites within the chylemic membranes. And there's no strong clinical experimental data that proves this particular theory. Now we go into the concept of metastasis. So this was theorized by Hanan in 1924. So basically he's stating that endometriosis spreads like a cancer, hematogenically or through lymph nodes or through the lymphatic system. And that's how we can explain the more rare and remote areas of endometriosis, such as the lungs, for example. 30% of women can present with endometriosis in the pelvic lymph nodes. The other concept is the altered immunity concept. So basically, it's stated that the reduced immunological clearance of viable endometrial cells from the pelvic cavity can result in these deposits being present within the abdomen, and it's also proven by the fact that higher concentrations of activated macrophage and decreased cellular immunity and repressed natural killer cells cell function are all present within endometriosis. Now, the pitfalls in this situation. Yes.
يا دكتور حنان، شكله الصوت بيطلع صدى. Can we go a little bit closer to the mic?
Sure, of course.
Get closer to the mic, and probably if we go a little bit slower, probably it's a little bit fast for the people.
No problem. Okay.
Sure. إن شاء الله يكون الصوت كده أحسن بإذن الله. إن شاء الله. Sorry for disturbing you.
No, it's absolutely fine.
Thank you very much.
Okay, so back to altered immunity. So altered immunity, as I said, there are higher concentrations of activated macrophage, decreased cellular immunity, and repressed natural killer function within endometriotic implants. The pitfalls in this particular theory is that there is no evidence that supports that patients with suppressed immunity have a higher incidence of endometriosis. The next concept is the genetic concept. Now, women have a 7-time greater chance of having endometriosis if they have a first-degree relative that has endometriosis as well. This is a concept that's being studied more and more in recent years. So I don't want you to really worry about what I was talking about with regards to the theories of endometriosis. I think the bulk of information is going to be from now on, and particularly with management. And I'll definitely try to slow a little bit down when it comes to that so that you can all grasp the concepts. So the anatomy of endometriosis. Why do we need to understand the anatomy? Now, it's important for us to understand where are the common areas where we can find endometriosis. And this will also help us in order to be able to facilitate further management, or in order to be able to increase our clinical suspicion at the time of presentation of patients with with endometriosis. So in this particular study, this study looked into anatomic distribution of endometriosis. It was a reappraisal based on a series of 1,101 patients who were consecutively entered laparoscopically to confirm a diagnosis of endometriosis. Mostly, endometriosis was noted in the ovary, and this is the more common area, followed by the uterosacral ligament, ovarian fossa, pouch of Douglas, and bladder. Now, these areas are very important for us to keep in mind, because later on, when we're going to look into diagnosis or diagnostic laparoscopy, we have to know where we're looking in order to be able to understand, in order to be able to really benefit our patient. Now, 14% of these patients had deeply infiltrating endometriosis. Deeply infiltrating endometriosis is a solid endometriotic mass that's situated more than 5 millimeters deep to the peritoneum. So it's not just superficial over the peritoneum or superficial over a certain organ. It actually infiltrates within a certain organ or within the area that it's at. Now, less commonly, we can find endometriotic deposits in the vagina, cervix, rectovaginal septum, cecum, ileum, and so on and so forth. And we're going to go into a little bit of detail later on. Now, it's good for us. I think this, I'm always one to prefer images that make things simple for me to remember. And I love hierarchies as well. You're going to see from this presentation. So basically, it can be pelvic or extrapelvic. Pelvic, as I mentioned, the more common areas are the ovaries, the tubes, peritoneal pelvic within the peritoneum of the pelvis itself, the vagina, the bladder, rectum and sigmoid, colon, uterosacral ligament, the cul-de-sac, and the pelvic sidewall. And on the other hand, the extrapelvic sides, gastrointestinal system, and the urinary tract are more common. However, it has been noted in the lung, the pleura, as well as the liver. And we're going to look a little bit more into that later on. So, diagnosis and clinical manifestation. And I think this is the area where everyone is going to be very interested, and I think it's going to be very good for us to just try to increase our level of concentration, because this is where we really get into the bulk of things. So this is just a simple diagram that looks into the whole approach into endometriosis. I'm not going to go through it, but I suggest if there are any residents or students out there, this can really help you keep things structured. So take an image, take a picture, and we will, and I think this will help you later on. It definitely did when I was studying. So the risk factors for endometriosis, there are many risk factors, but the more common risk factors include early menarche, late menopause. So here we're talking about a longer period of menses. So this maybe goes with the theory of retrograde menstruation. So a longer period of menses, a longer ability for retrograde menstruation to occur. First degree relatives with endometriosis, as we said, earlier, Müllerian anomalies. And this is a very interesting concept because Müllerian anomalies increase the risk of retrograde menstruation. And there are a lot of girls and women that present with endometriosis secondary to Müllerian anomalies. So basically outflow tract anomalies. The other thing is nulliparity and infertility in itself could be considered a risk factor, as well as prolonged menstruation or short menstrual cycle. Basically, when it comes to the presenting symptoms or the presentation, it's always easy for us to put things into triads, I guess. So the most common presentation for endometriosis is a triad of dyschezia, dyspareunia, and dysmenorrhea. Or maybe let me correct the order: dysmenorrhea, dyspareunia, and dyschezia. And this is kind of pathognomonic, actually, when it comes to diagnosing patients with endometriosis. However, we have to also look into the other symptoms or clinical presentations, such as chronic pelvic pain, infertility, dysuria, which could be present with patients who have endometriosis within the urogenital tract, PR bleeding and hematuria. So this is for people who may have endometriotic deposits in the bladder or in the bowel. And this usually is a cyclical PR bleeding and hematuria. Cyclic dyspnea. Now this is the catamenial or the pleural or lung endometriosis. And this is, the patients can actually present with shortness of breath and may require imminent emergency management. And finally, leg pain or sciatica, and this would be more towards the infiltration of endometriosis or endometriotic deposits on nerves. So a focused examination. Now, when we're talking about examination, any patient we have to examine them thoroughly, especially if it's the first time for them to present to our clinic. However, when it comes to endometriosis specifically, we're looking at an abdominal examination, and this can help us assess if the presence of any masses, as well as mapping the tenderness for the patient. So it can give us a clinical clue of if there is endometriosis, where does it lie? A speculum examination. Now, a speculum examination can help us to diagnose vaginal endometriosis as well as diagnosing a deviated cervix. So if there is dense adhesions or dense endometriosis within the pelvic cavity, it can actually result in disposition of the uterus, and deviated cervix would be the result. Here you can see some vaginal deposits, as well as the cervix not really centralized as we usually see in a normal examination. Finally, a bimanual and rectovaginal exam, and these are absolutely essential when it comes to evaluating a patient with endometriosis. It can help us see the size, the mobility, and the position of the uterus, if it's retroverted, anteverted, if it's fixed and immobile. We can also palpate the fornices and the rectovaginal tissue and parametria. Here, this will be something that will help us when it comes to mapping out where the endometriotic deposits are probably found. Now, when it comes to diagnostic tools, we have so many tools that can help us to assess endometriosis. But I think one of the most important things for all of us to know is that there is no pathognomonic laboratory findings that help us diagnose endometriosis. And a lot of people are going to be asking about CA-125 and so on. CA-125 and so on. So basically, CA-125 has a poor sensitivity as a lone marker for endometriosis. It also has a specificity of 85%, but the sensitivity is extremely poor when it comes to the diagnosis. So why should we do it? Basically, CA-125 can help us monitor the treatment response later on. So when I start giving any medical treatment, or when I carry out a surgery, it may help us to monitor our management, whether or not the patient is responding. And it can predict the prognosis and poor outcome, and which patients are going to have a poor outcome when it comes to our decision on management. So ultrasonography, and I think here, from this part onwards, we're going to be looking at a lot of images. And I think it's very interesting for us to really be able to understand and correlate between ultrasonography and surgical, and what happens in the surgery itself. So we're going to start off with a simple image, which is an image of an endometrioma. And in this particular image, you can see the ground glass appearance, or you can see the ground glass appearance, or let's say the salt and pepper appearance. And this is very, it's very specific for endometrioma. However, it can be seen in other pathologies as well. Later on, I'm going to put a comparative picture of different ovarian lesions. Again, this is another image with a similar finding. However, it's more echogenic. Again, in this particular patient, she has 2 cysts. In the left side, it's a simple cyst. However, on the right side, it is an endometrioma. So you can see the comparison. It's very easy to tell the difference between the 2 cysts. In this particular image, you can see here, this is a transvaginal scan. This is the bladder, and this is the uterus. And here you can notice a bladder nodule. Again, you can see the ground glass appearance, which is very which is similar to that found in the endometrioma. In this particular image, maybe it's not that clear, but this was also through a transvaginal scan that showed a rectal. An endometriotic deposit within the rectal septum. Maybe it's not that clear. I'm sorry about that. So in this particular slide, we're looking into the differentiation between different cysts found within the ovary. So it's, again, the ground glass appearance associated with endometrioma. How do I differentiate it from a hemorrhagic cyst? Because this looks very similar to a hemorrhagic cyst. However, when we're looking at a hemorrhagic cyst, we're looking at a lace-like appearance within the cyst itself. So this is what we're talking about, these fine threads that give us an image of more of a clot, a collection of clots within the cyst. Now, when it comes to dermoid cysts have, let's say, a mesh, or let's say what they call similar to a web or a spider's web, and also there's calcification. So you find the colors, it's more echogenic as opposed to other cysts found on ultrasound. And in this particular image, there's a Rokitansky nodule. And finally, a simple cyst. A simple cyst is just a very dark black cyst, and it's very clear. It has no components within other than a clear fluid. I hope that this image...
Yeah, there was a comment about شوية شكله السبيد. Can we slow down a little bit, because there are some are finding the speed is a little bit too fast.
Okay, I apologize for that. Sorry.
And there's one question, if you can go back to explaining the salt and pepper. Okay. Someone,
okay,
because
we can look at
about,
we can look at it here.
Yes, excellent. So let's try to slow down a little bit for the audience, please.
What's the question?
كان على explaining the salt and pepper. You described the image of the endometrioma with the ground glass appearance or the salt and pepper. So I think it's just a description of how it appears by us. If you can describe a few words about that, please.
Okay, sure. So basically, it's a well-circumcised cyst within the ovary. What you're going to find is black and white dots. So what I can say is, go to your kitchen, get some salt, get some pepper, and throw it and throw it and mix it together. it gives you small black and white dots, and this is what the description of salt and pepper appearance means. That it's not homogeneous, but it has these black and white deposits, let's say. I hope that this makes sense to you, but this is I think as best as I can explain it. I hope whoever asked the question can give us an okay. I'm going to move on for now. Okay.
So is this clear? I just want to ask Isra, who asked about the salt and pepper. Is it clear for you? Yes, excellent. Thank you very much, Hanan. Please go ahead.
Okay. Thank you. So in addition to ultrasound, there are other modalities that can help us diagnose, especially the deeply infiltrating endometriosis. So when we're talking about patients who present, let's say with rectal bleeding, a colonoscopy can be very helpful, and these deposits will show in a similar fashion to what we will see later on in endoscopy. Laparoscopic surgery. Now, when it comes to a rectal ultrasound, it's not really commonly used. However, it can be helpful, especially when we're concerned about rectovaginal septum or rectovaginal septum lesions. A cystoscopy in those patients who present with hematuria. So again, in this particular image, you can see an endometriotic deposit. This endometriotic deposit within the bladder through cystoscopy. And finally, an MRI. Now, an MRI isn't really routinely used. However, it can be helpful in certain situations, especially when we're trying to map out our surgical intervention. Okay, so this is an interesting study that looked into a comparison between clinical examination, transvaginal sonography, and magnetic resonance imaging for the diagnosis of deep endometriosis. In this particular study, they actually compared all of their findings through examination, MRI, and TVS with a post-evaluation laparoscopy. So when it came to the sensitivity and specificity of finding lesions or suspecting lesions within the rectosigmoid or rectocervical sites, and a digital examination actually had a very good sensitivity, however, a questionable specificity. When it comes to a transvaginal ultrasound, the sensitivity and specificity was very high. So it can really help us if we have a very good ultrasonographer who knows what they're looking for when it comes to the diagnosis of endometriosis. When it comes to MRI, again, there is a good sensitivity and specificity. But the transvaginal ultrasound surpasses both a clinical examination and an MRI when it comes to diagnosing deeply infiltrative lesions within the rectosigmoid or the rectocervical sites. So it just goes to show you how important it is to have someone reliable in an ultrasonographic point of view in order to be able to help us with managing patients with endometriosis. So the gold standard diagnostic tool, as we all know, the gold standard diagnostic tool is laparoscopic surgery. And basically what it does is that it can help us visually confirm the diagnosis of endometriosis, as well as it allows us to get biopsies so we can have a histological confirmation. In expert hands, and what I mean by expert hands is years and years of dealing with endometriosis, a diagnostic laparoscopy can actually be considered diagnostic without the histopathology, just by visualization of these lesions. So in this particular study, accuracy, it looked into the accuracy of laparoscopy for assessing patients with endometriosis. It was a center-based study on patients who are undergoing laparoscopy due to pelvic pain and infertility. And it showed that that out of 468 patients with laparoscopic findings of endometriosis, 337 were confirmed histologically. Among the remaining patients who did not have any findings of endometriosis, 8 were diagnosed with endometriosis. In comparison to histopathology, laparoscopy alone can represent 97% sensitivity and 79% specificity. What does this mean? This basically means that laparoscopy is a very good diagnostic tool for endometriosis, even without a histological assessment. However, not finding any lesions of endometriosis does not rule out endometriosis. So I think this video is a very important video, and this goes back to the slide of anatomy. So when I was talking about anatomy, I was specifically focusing on the areas where we can find endometriotic deposits. And this is a very good video that looks into having a proper examination of the pelvic cavity. So he's looking at all the peritoneal surfaces. He's lifting the ovary to look at the ovarian fossa. You can see lesions on the ovary itself. Here, they're polypoid lesions. You can see purple discoloration on the peritoneum. And this area in particular shows adhesions, which is a common finding in endometriosis. Again, another purple deposit that's pathognomonic for endometriosis. We can repeat this video later on. The next few slides, again, are going to be images. I think it's very important for us to look at pictures in order for us to be able to understand what we're seeing when we're going into the operating room. So when it comes to, I hope my speed is okay. Please, I hope that you're all okay with this rate. So basically, here you can see a peritoneal deposit of endometriosis. Again, this is a purple or let's say a dark red deposit of endometriosis. It's secondary to the presence of hemosiderin within the actual deposit itself. One of the pathognomonic findings for endometriosis is what they call a powder burn or a gunshot burn. So basically, these dots around the endometriotic deposit that are, let's say, new or upcoming lesions of endometriosis. Again, this is another image of endometriosis that looks or another way that it can present, which is in a polypoid feature. This is more extensive endometriosis, and as you can see, this is attacking or present in a more wider space. And this does look like what we usually see intraoperatively. As you can see here, these white bands are of adhesions. These are the deposits themselves. In this particular image, we're looking at surface endometriosis on the bladder. We still haven't seen any endometrioma, so let's not get confused. But these are the same deposits that we're seeing within the peritoneum. Another image of an ovary. This is the ovary with surface deposits. In this particular patient here, you can see a small endometrioma within the ovary, and I think we're going to have a couple of better images. For example, this one. So basically, the endometrioma is a big collection of endometriotic tissue, and it's one of the distinctive features that we tend to call it is a chocolate cyst. So basically, if we open into the cyst, this is what we're going to find. We're going to find this dark brown, reddish liquid that's found within it. Again, this is Again, this is an image of a cyst that has been opened. And now these next few images look at how extensive adhesions can be. So the position of the ovary has actually shifted to a completely different position, and it's more attached to the uterus. Again, this is a kind of a nastier endometriosis. All of these images are from varied resources, but mostly from UpToDate and from Comprehensive. And again, this is a patient with bilateral endometrioma and dense pelvic adhesions. And one of the things that we have to always remember is that when we're doing a diagnostic laparoscopy for a patient where we suspect endometriosis, we have to look at the appendix, because that almost 7% of patients with endometriosis can present with appendicular endometrial deposits, as seen in this particular patient. And finally, this is diaphragmatic endometriosis, or endometriosis near the liver, with adhesions between the liver and the anterior abdominal wall. And this is also an image of diaphragmatic endometriosis. Here, it's important for us to remember that positioning during OR or during laparoscopy can be very helpful when it comes to thoroughly looking for endometriotic deposits. So in this particular situation, when we're looking at the diaphragm, a reverse Trendelenburg position can be helpful for us in order to be able to look better or see the diaphragm behind the liver. Usually in the diaphragm, the lesions are very superficial. Rarely are they deep enough to require resection. So through the American Society for Reproductive Medicine, they have classified, or they have created a way for us in order to be able to stage endometriosis. And this looks at, it's completely dependent on having a proper and thorough examination during diagnostic laparoscopy. So it looks at the position of, or the site of the endometriotic deposit, and scores it according to size. Also, whether or not they're deep and infiltrating or just superficial lesions. Again, it requires a very skilled person or a very skilled physician in order to be able to get a proper staging or a proper scoring, pardon me, for endometriosis. Now, a score of more than 40 is generally noted as severe endometriosis, and this usually means that there could be an endometrioma, and endometrioma is always considered a severe form, and dense adhesions that are obliterating, let's say, the pelvic cavity or affecting the abdominal cavity as well. So this is an image. This is something that I don't think anyone will memorize as much as gain with experience how to score a patient with endometriosis. Now, this is an image that's usually together with that scoring paper that shows the stage of endometriosis and the extent of endometriosis and what stage it would be considered. So now we get into the nitty-gritty of things. We need to focus now on the management. I think it's important for us here to say endometriosis should be viewed as a chronic disease that requires lifelong management plan with the goal of maximizing medical treatment and avoiding repeated surgical procedures. Now, any patient with endometriosis suffers. They're either suffering from severe pain affecting them socially and psychologically, or suffering from infertility affecting them, affecting the patient's need for maternal need, and affecting the patient psychologically as well. So what we need to understand when it comes to management of endometriosis is that it is really dependent or focused on what the patient wants, what the patient needs. We have to cater our management. Here we're going to talk specifically about managing pain when it comes to endometriosis. It's a very long topic. However, again, this is an image that can help you structure yourself when it comes to looking into the management of endometriosis. I'm not going to be focusing today, as I mentioned, on infertility. However, we're going to be talking about mostly pain. We're going to be talking about the medical management and the surgical management of pain in patients suffering from endometriosis. We're going to start off with medical management. Now, with anything that we focus on, we have to, with anything that we approach, we have to look into the advantages and disadvantages of our approach. So when it comes to medical management, the advantages of medical management is it gives us the ability to avoid damaging important pelvic structures or important pelvic organs. And this is what we're going to talk about later on when it comes to preserving ovarian function. It also avoids post-operative adhesions. As we saw from all the images laparoscopically previously, there can be extensive adhesions associated with endometriosis. And as we know, surgical intervention can increase those adhesions. And finally, it can actually help us treat implants that are otherwise not seen surgically. So some implants are either new or small or cannot really be seen on the surface of the peritoneum. And generally these can be affected or can be treated adequately using medical management. Now, when it comes to the disadvantages, when we're talking about particularly hormonal therapy, there are a lot of side effects that can be experienced when it comes to utilizing hormonal therapy. Again, the recurrence after discontinuation. After I discontinue the medication, I'm not suppressing the ovarian function anymore. And I'm not suppressing the hormones, the estrogen anymore. So basically, there is an increased recurrence after discontinuing medication. There is no effect on existing adhesions. Adhesions can only be treated or reasonably treated surgically. There is no effect on endometriomas. Endometriomas, as we're going to discuss later on, are treated surgically only. Finally, treatment involves suppression of pregnancy, and this may not be very helpful when it comes to patients whose focus is to treat infertility. And there's no effect on infertility when it comes to the medical management. So by giving our medication, it doesn't increase the possibility of spontaneous pregnancy. So let's start with simple initial management. As we said, endometriosis presents with pain. And it's been thoroughly studied in multiple Cochrane systematic reviews that the best medication for treating pain or best analgesic for treating the pain of endometriosis is NSAIDs. So our NSAIDs, and we're talking about, as you know, ibuprofens. We're talking about mefenamic acid and so on. They're thoroughly available, very cheap, and they have acceptable side effects. And there are, as I mentioned, good evidence that prove its effectiveness as in pain control. Now, let's say our primary treatment or our first-line treatment is always combined oral contraceptive pills in those patients who do not have any contraindications to the utilization of combined oral contraceptive pills. Basically, they help cause atrophy to the endometrial tissue, to the ectopic endometrial tissue, reducing the effective estrogen and thus reducing the pain. It relieves pain, both relieves pain and retards progression. Now, when it comes to managing initial therapy can be actually started empirically and solely based on clinical suspicion. So if I have a patient, I highly suspect endometriosis, and we don't want to, there's no room or to go for surgery at the given time, starting off with analgesia and starting off with combined oral contraceptive, monitoring the patient can be a very good initial treatment. Using combined oral contraceptive pills, usually we're using them in a cyclical manner, and it's been noticed to reduce pain both associated with dysmenorrhea, the cyclical pain, and dyspareunia and non-menstrual pain. The next type of management, if we fail to manage using combined oral contraceptive, or if there is a contraindication to use combined oral contraceptives, what we go into is progestins and anti-progestins. So when it comes to progestins, we're talking about inhibiting the endometriotic tissue in a similar fashion to combined oral contraceptive, causing atrophy and regressing the amount of development or the amount of progression of the disease. They also inhibit pituitary gonadotropins and ovarian hormone secretion in a similar fashion to combined oral contraceptives. When it comes to antiprogesterones, the only antiprogesterone, or let's say one of the few antiprogesterones that have been studied or looked into in randomized controlled trials was gestrinol, and it showed significant improvement in menstrual pain and dyspareunia. However, there is a lack of placebo-controlled trials, so this information should be utilized with caution. So when we're talking about progestins, these are the well-known or the commonly known regimens that we utilize for the treatment of endometriosis. Either medroxyprogesterone acetate, norethindrone acetate, depomedroxyprogesterone acetate as an injection, and even the utilization of the levonorgestrel IUD has been proven to improve symptoms of endometriosis. When we're talking about the depomedroxyprogesterone acetate, we have to look into the side effects that include irregular menstrual bleeding, nausea, breast tenderness, progestinic symptoms, breast tenderness, fluid retention, depression, and reversible loss of bone mineral density. And when it comes to the IUD, again, we're talking about irregular menstrual bleeding, nausea, breast tenderness, and fluid retention. Okay, I'm not going to go through the doses, but I think it's very important for us to know them. So again, to all the students, and residents and people practicing, just keep a photographic clip of this slide in order to be able to remember them later on. And I don't mind sharing my slides later on. The next group of medication that we're looking into are GnRH agonists. So GnRH agonists, again, have been proven to relieve the pain and reduce the size of existing implants. When it comes to GnRH agonists, due to their side effects, we always utilize them with add-back therapy to control these side effects. It's been proven that when compared with goserelin and so during the treatment with GnRH, there has been proven to have reduced pain with regards to dyspareunia, dysmenorrhea, and as well as non-menstrual pain as compared to the baseline presentation. These are the most common medications or GnRH agonists that are utilized and that are on the market, and I think they're available worldwide. Lupron acetate, which can either be used as a monthly or every 3 months regimen, and nephrolin acetate, which is a nasal spray regimen of GnRH. Now, when it comes to the ESHRE recommendation, the ESHRE recommends, and actually most of the societies recommend the utilization of add-back therapy in order to reduce to avoid the reduction of bone mineral density. And in fact, they avoid it completely in younger women who may have not reached their full bone mineral density. Danazol, I'm going to talk briefly about danazol. Now, when it comes to danazol, it has been proven to be very effective in the treatment of pain. However, it has significant androgenic side effects, including, but not limited to, acne, muscle aches, edema, weight gain, also deepening of the voice. So it does have a wide array of symptoms that are not pleasing for patients who have utilized it. When it is utilized, the recommendation is for patients with rectovaginal endometriosis. There is a vaginal regimen that can be used, that can be helpful. Also, it can be given orally. But again, its usage is extremely limited. Aromatase inhibitors is an interesting area of consideration. So they're considered in patients who have painful rectovaginal endometriosis that's refractory to either medical or surgical. So it's never used as an initial treatment. It's used in patients in combination with oral contraceptive pills, progestogens, or GnRH analogs as they reduce endometriosis. The common utilized aromatase inhibitors are letrozole, and usually they're used in combination with desogestrel or in combination with other combined oral contraceptive. The side effects of aromatase inhibitors are mostly hypoestrogenic in nature, so patients will have symptoms of postmenopause, vaginal dryness, hot flashes, and diminished bone mineral density. Again, giving us a reason why it's not used as an initial management. So when it comes to, we're going to move on now to surgical management. When it comes to surgical management, there are certain indications for surgical management. And usually these indications are severe incapacitating acute symptoms. So patients who present, for example, with a severe acute abdomen, patients with an endometrioma that may have torted or that may have, torted. These patients require acute or immediate emergency surgical intervention. Patients who have a poor response to medical treatment. Usually when we're giving any medical intervention, we follow up our patients every 3 to 6 months, either with a good clinical examination and history in order to map out the pain or the pain history during the utilization of the medication. Obstruction of the bowel or urinary tract. So in patients who may have bowel or urinary endometriosis, these patients will require imminent surgery. Patients who have any contraindication to the utilization of our medication, as you saw, mostly it's hormonal, and those patients who refuse the utilization of medical therapy. And finally, in order to exclude malignancy, as we're going to be going in and taking an actual physical tissue. So the advantage and disadvantage of surgical management. Again, the advantage is to be able to really confirm our diagnosis. We're going to have a histological diagnosis. And it's been proven that the surgical management, if done properly, it can reduce the pain significantly for these patients. The disadvantages, we go into the risk of injury to visceral organs. As you saw, endometriosis can cause dense adhesions, can cause disease in a varied array of areas within the abdomen. So there can be a risk of injury to particularly the bowel and the bladder. There is a risk of reduction of ovarian reserve, and this is seen in cases of endometriomas. Again, we're going to talk a little bit more about this later in a little while. And an increased risk of adhesion formation. Is another disadvantage of surgical management. The concept of surgical management, so basically whenever we decide to go for a diagnostic laparoscopy, generally we are going to treat. So it's not solely to diagnose, it's also to take samples and to treat. And the basic principle is to see and treat as much as possible or as physically possible for the clinical skills of the particular physician taking this case. And here it's important for us to reinstate the importance of having a multidisciplinary team, even in surgical practice, when it comes to treating endometriosis. So the treatment of endometriosis can either be conservative or definitive. Conservative treatment, we're talking about the surgical treatment by laparoscopy or laparotomy. Now, the favoring of laparoscopy is mostly due to its less to having a less surgical post-surgical recovery time, a more cosmetic appearance post-operatively, and less requirement of analgesia post-operatively. But what we're talking about here is ablation or adenolysis that that can relieve the pain. The other thing is, of course, is the cystectomy. Again, I'm going to be focusing on endometriomas separately. However, there is a chance of recurrence when it comes to conservative management. And here, this is where it's important for us to define which people, who we're treating. What's the primary goal of our patient? If the patient is required pain control, conservative management may be the better option for her. However, if the patient is requiring future fertility, conservative management may be the better option for her in this situation. However, definitive management also has its pitfalls. So definitive management is generally in the form of total abdominal hysterectomy or laparoscopic hysterectomy and bilateral salpingectomy, plus or minus oophorectomy. Now, this can be done in the case of persistent incapacitating symptoms and in those patients who have no desire for future fertility, and in patients with coexisting pathologies. Now, there is a significant proven benefit for laparoscopic surgery in the management of pain 6 to 12 months ahead of after the procedure. So patients can actually have complete pain management with the surgery post-operatively for almost a year. The method of treatment in these patients was either excision of the lesions or coagulation or laser vaporization of the superficial endometriotic deposits. The next slide, we're going to be looking into the surgical interruption of pelvic nerve pathways. Now, it's always good to ask ourselves some questions, and when it comes to managing pain in these patients. So, one of the questions that you're going to be routinely seeing when talking about management of pain is: can laparoscopic uterosacral nerve ablation, or otherwise known as LUNA, reduce pain associated with endometriosis? So there are many studies that have looked into this, randomized control studies that have looked into LUNA, and they have proven that this technique did not offer any additional benefit as an adjunct to conservative surgery when it comes to managing endometriosis surgically. However, if we're looking at presacral neurectomy, so can presacral neurectomy reduce the pain? There were significant benefits, specifically at 6 and 12 months in 3 randomized control studies that showed that there is an improvement of pain. However, we have to keep in mind that there is an increased risk of adverse side effects, such as bleeding, such as constipation, urinary urgency, and in the future for pregnancy, a painless first stage of labor. So we have to approach it with caution. Now, as I promised, we're now going to be discussing endometriomas alone. So when it comes to endometriomas, there is still a role of observing endometriomas as a cyst, as any cyst, especially in those patients who have asymptomatic endometriosis or endometriomas and smaller endometriotic cysts. Usually we're talking less than 5 centimeters in size. But again, the most important issue we're talking about here is asymptomatic. So the patient is able to tolerate her pain. However, in patients who are symptomatic, the goal of treating endometriomas is to relieve the symptoms. It also is to avoid complications. The larger the cyst is, the higher the risk of the patient presenting with acute abdomen and torsion. The other thing is, pardon me, the other thing we look into is if there are any ultrasound findings that give us a suspicion of malignancy, more complex cyst as seen on ultrasound. This can help us exclude malignancy, so because we're going to go in surgically and we're going to see the abdomen itself. Finally, it can also help treat subfertility and preserve ovarian function. And now there's an interesting study that looked into cystectomies for endometriomas and the increase of spontaneous pregnancy in patients that were otherwise rendered subfertile. The principle is to excise and reduce the pain and the risk of recurrence. And in these patients, there is still a small risk of recurrent endometriomas, but when it comes to repeated surgery, this should be really based on the severity of symptoms and the size of the cyst or the recurring cyst. So this study is what I was talking about, excision therapy versus ablative therapy for ovarian endometriosis. So this was a Cochrane database systematic review that looked into randomized controlled trials, and it proved that laparoscopic excision of cyst wall helped to significantly reduce the recurrence rate of symptoms and the need for recurrent surgery. There was also a subsequent increase in spontaneous pregnancy rates in patients who were previously subfertile. Finally, excision surgery provides a more favorable outcome than drainage and ablation, as drainage and ablation have an increased risk of recurrence. Okay, another question that we need to ask ourselves when it comes to surgically managing endometriosis is, does hormonal pre-treatment benefit our surgical, our surgery? Does it reduce the extent of surgery needed? So when it comes to the role of hormonal pre-treatment, there is no evidence that proves that preoperative hormonal therapy can actually reduce the extent of surgery or prolong the duration of pain. In fact, there's no proof that it can either increase fertility or decrease recurrence. So there's no role for hormonal pre-treatment prior to surgery. However, post-operative treatment is beneficial. So it can increase the duration of a pain-free period post-operatively. And usually, the expected duration is to utilize post-operative hormonal treatment for more than 6 months in order to prevent recurrence and to improve the pain. So, in simple terms, the management of endometriosis, initially we start, if we suspect endometriosis, we start with continuous combined oral contraceptive pills. In patients where combined oral contraceptive pills and analgesia failed, we go on to the many alternative medical managements, keeping in mind the patient's wishes, keeping in mind the patient's any contraindications the patient may have. And the other option is diagnostic and therapeutic laparoscopy. If both of these managements or if both of these plans fail, then maybe we have to take a step back, reconsider the diagnosis, involve chronic pain management or chronic pain teams, and to involve a multidisciplinary support, including psychosocial help. So that's it. So that's it for now. So the summary for our for my lecture, I think it's important for us to have a high clinical suspicion for factors that increase the likelihood of endometriosis. We have to keep in mind that the management is catered to presenting symptoms and patient desires. Medical management should be continued for at least 3 to 6 months with close evaluation before rendering it failed. Excision is superior to fenestration, drainage, or ablation, particularly when I'm talking about endometriomas, and the need for a multidisciplinary team to manage endometriosis is essential. These are my references. These are really important sites and important societies that will help us forever in developing our education and developing our practice. Thank you very much.
Thank you very much, Dr. Hanan. It was a very nice presentation, very nice talk.
I'm sorry for the speed.
That's okay. So now, yes, now in regards to the slides, you're gonna find the whole presentation on YouTube. So you're going to be able to watch it again, and probably if you have missed any kind of information while during the talk or you came in late, you're going to be able to watch it. So going to the question, there's a question that the salt and pepper for endometriomas or adenomyosis. So you're using the term salt and pepper for which one of them?
So basically, the most commonly used terminology for endometrioma is the ground glass, but it's also the salt and pepper appearance, because they have a very similar look. Now, endometriosis is, when we're talking about endometriosis, endometriomas, I'm talking about a lesion found within the ovary. When you're talking about adenomyosis, you're talking about a similar histopathological lesion found within the body of the myometrium. So they do look very similar, but you have to differentiate the site. Don't mix those two things up. Adenomyosis is a different site to endometrioma.
Sure. Now, another question was, when do you actually start doing the workup for malignancy to exclude ovarian cancer or melanoma?
Okay, so this is a very interesting question, and I think this could be well covered if we look into doing approach to adnexal masses. But in simple terms, when it comes to ruling out malignancy, we have, and I'm going to be talking specifically as a generalist. I'm not going to take my background in gynecology in this particular discussion. So we have a set of rules that we need to do, a set of things that we need to do when we have any patient who has an adnexal mass, correct? One of the most important ones is the ultrasound. An ultrasound has so many factors that can point us towards what could be malignant more than a benign etiology. When it comes to the ultrasound, we're looking at basically, first of all, not a simple cyst. So it's not simple. It has complex features. It has papillary projections. It has thick septus. Bilaterality of an ovarian cyst can sometimes point us towards the higher risk of malignancy. The other thing is the presence of ascites within the pelvis. Now, all of these things that I'm talking about are things that help general gynecologists refer patients to gyne-oncologists, which is simplified in the risk of malignancy index scoring system. I'm not going to go into too much detail. I think this is outside of the scope of the discussion, but it looks into the factors that I just talked about, as well as the premenopausal or postmenopausal status of the female, and finally, the level of CA-125. Now, when I'm talking about elevated CA-125 and endometriosis, I'm not talking about hundreds and thousands. I'm talking about a slight elevation, might be reaching 100, but generally it's in the tens. But when we're talking about a malignancy, we're going to be doing CA-125 as well as a long array of other tumor markers catered for the age group that we're presented with. So depending on the reproductive age or postmenopausal, including CA-125, carcinoembryogenic antigen, alpha-fetoprotein, beta-HCG, LDH as well, lactate dehydrogenase, and these will also help us to focus our management or our workup if we have a higher clinical suspicion of a malignancy.
There was a very frequent question, especially when you started talking about the staging of endometriosis. So can you shed a light again about a few, describing the stages of endometriosis and how to differentiate the stages, please? Can you go to those slides?
Sure. So the stage of endometriosis depends on a score that has been set by the American Society of Reproductive Medicine. So basically, it looks at different sites, the sites that I spoke about earlier. We have to look at the peritoneum. We have to focus on the ovary itself. We have to look at the posterior cul-de-sac and the presence or absence of obliteration, okay? So when it comes to, after that, we look into the presence of adhesions. So we're looking at three major things: endometriosis, posterior cul-de-sac obliteration, and adhesions. The endometriotic deposits being those deposits that are purple or dark, black, or polypoid in nature, and the adhesions being the white bands that we saw in multiple pictures. I can go back to them later on. and the posterior cul-de-sac. So as you saw in the video for the diagnostic laparoscopy, the surgeon was lifting the uterus in order to look behind the uterus. So we need to know and really thoroughly investigate the area in the posterior cul-de-sac. Each one of these findings is granted a score. I'm not going to go through the scores, but it depends on the size of the endometriotic deposit, okay? The size of the endometriotic deposit, our ranges are between 1 and 3 centimeters. Less than 1 centimeter has a lower score naturally, and more than 3 centimeters has a higher score. When it comes to the posterior cul-de-sac, can I mobilize the uterus? Can I mobilize the ovaries? Or are they densely adhesed? Is the pelvis frozen? If we're faced with a frozen pelvis, then we give a score of 40 automatically. And this score immediately moves the patient to a stage 4 disease. When it comes to the adhesions, again, we're looking at adhesions between the ovary and the tubes. How dense are the adhesions? How mobile are these structures? Can I move them around, or are they stuck to the peritoneal side wall? To the pelvic side walls or to the uterus itself? And based on the score that I get, I decide the stage of endometriosis. Now, when it comes to the stage, a lower score of 1 to 5 grants us a stage 1 or a minimal disease. A mild disease is 6 to 15. A moderate disease is 16 to 40, and more than 40 is a stage 5 disease, a severe disease. The funny thing is that keeping this in mind, I might go into a patient who is a stage 1 disease who has severe pain. And so the staging doesn't really actually necessarily correlate to the actual presentation of the patient. Is that clear?
Yeah, I think this is very clear. I would like to switch gears in asking about the tumor markers, like the role of CA125, and is there a role of CA19-9 as well in the presence of endometriosis? Because what I found personally is that these two correlate a lot, especially with young ladies with endometriotic spots or endometriomas. So can you shed light on that, please?
Okay, so when it comes to markers for endometriosis, I'm not going to call them tumor markers. I'm just going to call them markers. CA125, as I mentioned, CA125 is not diagnostic. It's not diagnostic at all, okay? But what it can help us, and it does not actually correlate. So the higher the CA125 doesn't correlate with the extent of the disease. But it can help us somewhat decide the prognosis or the response of the patient. Again, this is not, it's not something that a lot of people depend on. So not every patient with endometriosis requires a CA125 level. And again, it can help us monitor to a certain extent the management or the medical or surgical management in the future. So if the CA125 is reducing, then there is a higher probability that this patient is responding to our treatment, be it medical or surgical. I cannot give you anything regarding CA19-9 because specifically for endometriosis, I haven't had any reading that looked into CA19-9 specifically for endometriosis. There are other markers that are utilized, the protein peptide marker, anti-endometrial antibody. These are also things that are being studied at the moment as markers for endometriosis. But again, our main diagnostic tool or tool that helps us monitor our patients with endometriosis, especially when we're talking about pain, is a pain diary. Asking our patient, is the pain reducing, and the surgical intervention, like when we go in and we see what's going on within the pelvis itself.
Very good. I'm just going to take another 5 minutes out of your time, Hanan. There are a few more questions. Can you clarify the role of oophorectomy in women undergoing hysterectomy for the treatment of endometriosis if the patient
I
has
love this question. I love this question.
if the patient, yeah, you read this, right? It's in the chat. You read this.
Okay,
Considering regarding mature menopause, can it a reasonable justification to spare the ovaries?
Okay, so when it comes to removing the ovaries, there's a very interesting concept. Like when we're talking about endometriosis, we're talking about a hormonally responsive disease. So conceptually, it makes more sense. If I'm going to be doing a total, if I'm going to be removing the uterus, I should remove the ovaries the ovaries as well, because we didn't say that endometriosis is a pelvic disease. We said that it's a peritoneal disease. It's a chronic disease. It can be found everywhere in the body. Keeping the ovaries generally would mean that I'm keeping the source of the pain. Okay. However, we have to keep in mind that if I'm talking about a younger female who's in her 30s, in her late 30s, in her 40s, am I going to remove her ovaries and put her at risk of early menopause? Because early menopause is detrimental, and we know this. Do you think that she would want to live a life with hot flashes, with possible osteoporosis, with her psychosocial well-being, her psychological well-being, vaginal dryness for the next coming years, 20, 30, 40 years of her life? It doesn't make sense that we put her at that risk so early in her life. But again, we have to keep in mind that if the patient, let's say, her pain is really debilitating and it's severe, and she should be offered this option, we can remove the ovaries. And again, a hysterectomy, as we know, doing a hysterectomy and doing a salpingo-oophorectomy does put the patient at risk of an earlier menopause, even if it's just a few years earlier. So yeah, it's a very valid question, and I think it's a clinical dilemma. Will I do it or will I not? It really is patient dependent.
Well, thank you very much, Dr. Hanan. It was a wonderful presentation, a very nice talk, the way we had it here. Of course, there are a lot of questions, and I find a lot of questions that, please, guys, go to the Twitter account and within the group, type in the questions, and I'm sure Dr. Hanan will answer those questions to you, and we can have that discussion online. So because now we've already overcome the time, so please type in all your questions, whatever question that we did not answer, please put them into the Twitter account. Okay. Thank you very much, guys. Thank you, Dr. Hanan. Really appreciate your time and effort. It was a great, a wonderful time. Thank you very much, and good night, everyone.
Thank you, everyone, for attending. I really appreciate it. Thanks for your interaction as well. Thank you, Dr. Ayman.
Thank you very much. Sabah al khair.
Bye.